You've probably heard people say that emotions last only for 90 seconds and that they stay trapped in a body for 7 years. While these are popular ideas, science doesn't support those claims as absolute facts. What research does tell us is that emotional distress can influence how we experience physical symptoms. In chronic respiratory disease, this matters. I propose the term emotional breathlessness to describe the psychological and emotional distress that amplifies a person's perception of breathlessness, cough, chest tightness, and fatigue. The term emotional breathlessness does not replace anxiety, depression, breathing pattern disorder, or the dyspnea. Instead, it is a biopsychosocial framework and an easy to understand public term that's emotional breathlessness that acknowledges our emotion, thoughts, fear, and lived experience that shapes how respiratory symptoms are experienced by people with chronic respiratory disease. Imagine two people you might have actually witnessed in your clinical practice with the same lung function test may experience very different levels of breathlessness because our brain, our nervous system, and our emotional distress influence symptom perception. So, one is actually living independently, engaging with pulmonary rehab actively. The person is actually withdrawing from the care, ending up in the crisis hospital admission, costing the healthcare. Wherever you're placed in the world, whichever country, your healthcare system in that country is struggling to support you with a higher cost. So it's very important that we understand the term emotional breathlessness and apply it in our daily management of chronic respiratory disease. Recognizing emotional breathlessness reminds us that effective respiratory care is not just about treating the lungs, it's about understanding the whole person and integrating the psychological care with pulmonary rehabilitation to improve both breathing and quality of life.